Live.
Dear ESMO members and guests, dear colleagues, on behalf of the co-chairs of the Congress, Eric Van Kutsem and Mario De Cato, I would like to welcome you to this first day of the 22nd ESMO World Congress on Gastrointestinal Cancer, and especially to this clinical forum on new customized genomic signature tools for the prediction of risk in early stage colon cancer. And first of all, I would like to thank, of course, our sponsors, Natera and Alio Diagnostics, for making this session possible. These are my disclosures. Of course, today we have seen very important data presented in the session. First, Dr. Alexey Aleshin has provided us an update of the ctDNA assay for the detection of mycorrhizal disease and the opportunities that it offers with the Natera technology with the Signatera test. And later on, Dr. Marjan Levagus has provided us also important information, an update of the Immunoscore technology with the update of the new clinical data in this setting. So let me guide you through the most important and relevant data presented in this session, and more importantly, I would like to put this in perspective. So all the clinicians focused in the field of gastrointestinal malignancies, especially colorectal cancer, have been always focused on assessing the prognosis of the disease, in particularly in this setting for early stage colon cancer. And as you can see here, more than actually 10, 15 years ago, all the different societies, including ESMO, ASCO, and the NCCN network, have provided definitions on the high-risk patients, especially in stage 2. And as you can see, almost all the guidelines provide common features like the T4 lesions, tumors that present with perforation, poorly differentiated histology, or importantly, more recently, the inadequate sampling for lymph nodes. Some of these guidelines actually provide other factors, but there are, as mentioned, common features here. And of course, also for the stage 2, the initial assessment, whether the patient has a microsatellite unstable tumor or a microsatellite stable tumor. Later on, actually, several groups have developed signatures, mainly supervised signatures, but also unsupervised signatures that provide, based on the gene expression or the microRNA expression, also additional information on the prognosis of the disease. And you can see here many of them that have been developed in the clinical setting, but probably the one that has reached more accepted utility in the clinical setting is the Oncotype diagnosis. And as you know, this has been validated in 4 independent data sets coming from different clinical trials in different regions of the world. Interestingly and importantly, this diagnostic tool has had internal and external validation with this series, but also important clinical features like the T4 tumors and the MSI status has been included in the multivariate analysis. And at the end, this technology by Oncotype provides us information based on the gene expression in the tumor and classifies the tumor in high, intermediate, and low risk. One of the limitations, perhaps, that this may have is the lack of prediction for the use of standard chemotherapy, but some studies are actually addressing this field. Fortunately, right now, we have a more holistic evaluation of colorectal cancer, both in the early setting and in the late stage. And this is thanks to multi-omics technology. So we are integrating the clinical data. The clinical data continues to be very important, especially right now that we know the difference with the geographical patterns of the disease, whether the tumor is distal or proximal. But more importantly, thanks to all the genomics and epigenomics and transcriptomics technologies, we are implementing all the information for example, on the genomics, on whether the tumors are microsatellite unstable, whether they are chromosome unstable, also the mutational load and the copy number variation. For epigenomics, perhaps we are still in the more early stage in colorectal cancer, but several tests evaluating the methylation of some important genes are being evaluated. Of course, the revolutionary paper on the colorectal cancer CMS subtypes provided us information integrating the genomic data with the transcriptomic data and the pathways that were activated in these different subgroups of tumors. Remember that we had a total of 4 different subtypes. But more importantly, right now, also, we have the integration of important pieces of information about the stroma and about the immune microenvironment. And we know that not all the tumors have the same patterns for the immune microenvironment. And this is something that has been developed with some of these technologies that we are going to be mentioning today. But more and more, we are including all this important information in the evaluation that we conduct in patients with early stage, but also in late stage, especially in clinical trials. And as you can see here also, we have another piece of information that is becoming more and more important, and this is the microbiome, the gut microbiota, and also some viral infections that the patients may have had before. So the sum up here is that the characterization of the transcriptomic subtypes of colorectal cancer, of course encompassing tumor, stromal, and immune components, reveal clearly conversion pathway dependencies. What we have seen today as a next step of this are 2 different technologies, one that evaluates the tumor-immune interaction in the primary tumor, and this is the Immunoscore. And as you can see in this cartoon from the Alio Diagnostic web page, there are tumors that are more tolerogenic, others are immunogenic, and this is what this technology tries to address. But also, what we have seen with the colleagues from Natera and many investigators around the world is that the circulating tumor DNA is able to characterize and evaluate the presence of mycorresidual disease, what actually really is very important for addressing whether the patient needs adjuvant treatment or not. So the first one, the Immunoscore, I like to provide also information on the most seminal papers for each of the technology, and I think that this initial paper by Jess and the second one by Jeremy Gallon provide important information about this technology, especially with this international validation of the consensus Immunoscore for the classification of colon cancer. And as you can see here, with the clinical parameters, actually we provide a lot of power to the TNM stage and secondly to the differentiation and the belief score. But when we include the Immunoscore in all these studies, actually Immunoscore may have the higher relative contribution to address the risk compared to all the clinical parameters, including the TNM. So many data, the data that has been presented today, show the prognostic value of this technology. Nevertheless, whether this is predictive or not, even we have seen some interesting data, is something that has to be evaluated with more detail in the prospective randomized studies that are being conducted as we speak. The second technology, the technology presented by Natera on the cNatera test, actually relies on the potential for ctDNA in early stage colon cancer to predict the recurrence of the disease. And the situation is a little bit different between stage 2 and stage 3. In stage 2, in the cartoon shown on the left side, by the way, this cartoon is from also a very important review from Dr. Corcoran and Chandler in the New England Journal of Medicine. And as you can see, in stage 2, actually, the recurrence is around 10 to 15% of the patients, and only those are going to be who may benefit of chemotherapy. So actually, this technology has the opportunity to avoid chemotherapy in around 80 to 85% of the patients. The situation in stage 3 at the right side is a little bit different. Obviously, in here, more than 50% of patients may be cured by surgery, but actually around 45% of them may recur at some time point. And again, in here, this technology could eventually provide us information on which patients we should treat and even with which intensity we should treat them. Also, I like to provide information on one of the most relevant pivotal studies, I guess, that presented by Dr. Tai and later on published, where in this very elegant study, they provided information on the ctDNA in a cohort of patients with stage 2. And as you can see, the first thing that we see in the graph on the left side is that the postoperative ctDNA positivity or negative was very able to characterize which patients were going to recur. And this was actually true for patients that did not receive chemotherapy, but also for the patients that receive chemotherapy. Also, we were able to differentiate a little bit whether this effect was seen in those patients that were from a clinical perspective of low risk, and for those patients that were from a clinical perspective of high risk. And as you can see in these graphics, actually this effect, differential effect, was provided in all the different subgroups of patients with very impressive hazard ratios. And actually, in this analysis, postoperative ctDNA stayed to remain as a clear independent predictor of disease-free survival or relapse-free survival in this cohort of patients not treated with chemotherapy. Actually, what we know right now is that there are many different clinical trials around the world in different countries. Some of them are specific for particular countries. Some others are more international, both in stage 2 and stage 3, with different technologies. But as you can see, also some of them are doing more customized NGS tests, others with the Lunar one, and also with the Signatera technology that we have seen today. I'm sorry if I have missed, I'm sure I have missed some of the clinical trials that are ongoing. Sometimes information is not fully available. But the bottom line here is that the circulating tumor DNA is evaluated in many clinical trials, and the decisions based on these clinical trials in localized colon cancer are being evaluated, and will have more important randomized prospective data that will provide us information about that. It's very difficult after these very nice presentations actually to provide a summary of them, but I prefer perhaps to provide some take-home messages that are very, very general. I think that there is no doubt that these new technologies provide important information on prognosis. We have seen that for early stage colorectal cancer after surgery, but actually these technologies are also evaluated in other tumor contexts. For example, in patients with a stage 4 after the resection of metastases, we have some clinical trials evaluating the power of these technologies, also in the neoadjuvant setting. So I think that we are going to be expanding the field for the different situations in colorectal cancer and, of course, in other tumors. Also, there is very important emerging data, limited data, that may have some kind of predictive information. And we have seen also data on what is being mentioned as treatment escalation for those patients with high risk, or even for those patients that may not have the clearance of ctDNA, for example, that we would expect with adjuvant chemotherapy, but also treatment de-escalation that in some instance for some patients may be a reduction of the number of cytotoxics that they receive, but in others actually we can avoid chemotherapy. And I think that this is going to be an important area of research, and eventually we are going to be able to provide some important recommendations in the guidelines in the next future about treatment escalation and treatment de-escalation. As I mentioned before, I think that the ongoing clinical trials for both technologies, both for the Immunoscore, but also for ctDNA technologies like the Signatera and others, will refine the clinical indications, but more importantly, will provide the utility of these technologies. It's always important to balance how these technologies provide not only additional information, but how these can be implemented in our health systems, especially providing utility and in this setting. So I would like to thank all of you for being in this session, and I hope that you have a nice and very productive ESMO World Congress on GI cancer that, as mentioned at the beginning, on this year we are not in Barcelona. We are virtually connected, but I hope that you are going to be able to enjoy this Congress as you had in the previous ones. Thank you very much for your attention.